Okay, so we're going to be looking at the objective examination of the thoracic spine. And we'll first look at the observation, then go through the active, passive and resisted tests, then the neurological tests, and then special tests such as rib springing. Okay, looking at the patient with a thoracic problem. First off with these patients, if the pain is in the scapular area or above, then it really demands a cervical scan. Most of these problems will actually be coming from the cervical spine, so it's well worthwhile examining that first. Secondly, if they're coming from way down in the lower thoracic region, then a lumbar scan is probably a good idea. But if we're looking at the thoracic spine itself, on observation, we need to be looking for rib humps, and this is an easy area to see scoliosis because of the ribs. We need to look for hyper and hypo kyphosis. And you'll see a couple of different types of postural problems. One is the fixed hyperkyphotic patient with the big rounded thoracic spine, and then the hyperlordotic lumbar spine. And then there's a patient with the flattened thoracic spine that usually carries all the way down into the lumbar spine. So be aware of that. We'll look for scars, particularly pneumonectomy scars, and there we need to be looking underneath the arm as well as on the back and the front. Look for atrophy. Now, atrophy of the paravertebrals and the intrinsic muscles is considerably easier to see here than in the lumbar spine. And if you're really not at all sure, then we can palpate for that, and we'll discuss that in a second, but look for that. Look for hypertonus of these muscles. And again, this will stand out quite nicely. Having looked at the spine, run your hand down the spine, again feeling for ledging and wedging, as you did in the lumbar area. And now also you can palpate paravertebrally. Keep your fingers up against the side of the spinous process and push inwards. And we'll pick up either a normal tone in the muscle, or your fingers are dipped right in because of atrophy, or it'll feel hard on your fingers, which is suggestive of hypertonus, which is almost certainly from segmental facilitation. From the side, this part of the spine is actually very difficult to see whether or not they've got a hyper or hypolordosis, and this is better seen from the back. The reason for that is that the scapulae have different degrees of winging, and they can really make this area look kyphotic and hyperkyphotic when it's actually not. If you are interested in the posture at all, check to see the chin position in relation to the manubrium. Again, it should be sitting over the manubrium, but if it's not, it may well be because the problem itself is causing her to tuck her chin out a little too far, rather than the posture being a habitual. From the front, if we swing around this Beverly, we can look at the clavicles, and again, ideally they should be fairly horizontal, maybe a little elevated, but shouldn't be shrugged right up. Look for atrophy, particularly in the sternomastoid and trapezius area. If these are atrophied, you're looking at a cranial nerve problem. We'll come back to that when we look at the cervical spine. Look at the pectoralis major, and very often what looks like atrophy is actually a congenital absence of the pec major. So just be aware of that, and this can be unilateral or bilateral. Okay. All right, so we can move on from there into active, passive and resisted testing.